Good morning, everybody. I'm Steve Rommelfanger. I'm the Wisconsin Medical Director for the Aurora Palliative Care Program. Today, I have the pleasure of facilitating the Chalk Talk, Friday Chalk Talk, and with us today on special loan from CAPC, the Center to Advance Palliative Care, is Tom Gualtieri-Reed. CAPC is frequently collaborating with our Friday Chalk Talk endeavor, and so we're happy that anytime they're able to loan us one of their distinguished people. And so Tom is a partner with the Spraggins and Gualtieri-Reed consulting group. It's a national healthcare consulting company based in North Carolina that has helped with program development and business planning for palliative care and geriatrics programs nationally. Tom and his partner are frequent collaborators and presenters with the Center to Advance Palliative Care and have also supported major national planning initiatives related to palliative care, including National Consensus Project work, as well as National Pediatric Palliative Care Task Force and the American Academy of Hospice Palliative Medicine. I've heard Tom and his colleagues speak at many meetings, and I'm always amazed at the information and the context they present. So today we have the pleasure of hearing from him and learning from him. Hopefully you have some good questions. All right, Tom, if you're ready, please go ahead.
Great. Thank you, Steve and Marty. Appreciate the opportunity, everyone. I'm going to pull up my slides here. I do have a set of slides that we're going to clip through, and then definitely want to reserve a good chunk of time at the end for question and discussion. So I'll probably go about 18, 19 minutes or so. Just jumping in and talking to Steve and Marty on all of this, thought today we would focus in on metrics. Practical tips for how to begin to use and get comfortable with them. So often we're afraid to jump in on metrics for different reasons. On the one end of the spectrum, we worry about feeling like it's moving into a productivity world, and we are a very quality-centric and patient-empathetic practices. We are sometimes worried that the data is not right or accurate, those types of things. On the other hand, we can also use data and be excited about it. And some people can get really overly excited and drive so much of stuff only through data. So today, hopefully you'll get a sense of some practical tips about getting comfortable with it and really the balance across the two. First, we just wanted to lay the groundwork about why should we bother measuring? What is the importance of it? And there's a lot of factors that influence our work in this field. I mean, certainly the growing demand and expectations with the palliative care being much more becoming a standard of care, the expectations you might start being asked to see patients on the inpatient and in the clinic, and how do you argue for or position yourself to have the staffing to do that well. Changing roles is happening as well, too. Thinking about the fact if you integrate into a cancer clinic, you might be moving into more of a co-management role versus a consult only. That affects how your team and your program might be running. Lots of financial uncertainty and pressures. We all know that. And you as a system as well, too, are going through mergers and acquisitions. And sometimes that can create tension where folks are trying to compare different hospitals. And you need to know the local presence of what's happening. We all know the workforce stress that we deal with, not only in the complexity of the patients, but also just as a workforce, finding enough people to do the work that's needed. And then practice culture variations. What's happening at one hospital could be very different based upon how the practice culture works, what the team is comprised of. So all those factors can influence our work, and it kind of can feel like spaghetti, and we're trying to figure out what to do. So why is measuring important? Why should you believe that you need to do it? First point we just want to enforce is that it's better to know your own numbers to control the narrative versus having someone else telling you what they think your numbers tell you. So if we don't know our numbers better than others, we start to lose control of the conversation. Second, if it's not counted, it won't happen. Unfortunately, that's how it happens. But if you're expressing some frustration on feeling like volumes are higher than they are normally, and you don't know what normal looks like, it's hard to make an argument for it. So want to make sure that you're capturing numbers. Stewardship is a theme we'll talk about today as well, too. Capturing measures helps demonstrate good stewardship of the resources you have, thinking about how you are using the team and how the volumes are affecting what you're doing shows that you're looking at what you have and managing around those numbers and understanding them from a stewardship perspective and thinking about the consistent delivery. And then all that too feeds into, how do we plan for growth and demonstrate impact if we don't have some numbers? And that just opens up new opportunities for value. So those are just a couple themes just to kind of frame our heads about why it's good and healthy and okay to begin looking at metrics and how you might use them. We wanted to start with a perspective to realize that in our field and in these programs, a lot of different variables are working together. And so just looking at a number, you have to unpack it. So for example, in your program design, if you're seeing a lot of patients in the ICU, you might be spending more time up in the ICUs because that's where it might be a large impact. But that also might mean you're not able to see as many patients in some of the general medicine units. So you're spending more time seeing patients for a longer period of time with more follow-ups might drive your patient volume. So if your program design is in that population, it might look different than if you're on a general medicine unit where you might be seeing patients a little more quickly. Service features, if you offer 24/7 coverage or weekend coverage, maybe, that can affect how many patients you might be seeing. And then on the staffing plan side of it, the interactive piece there is you might have a full interdisciplinary team for which you're having the social workers and the chaplains really operating as part of the team. And they're able to see follow-up patients, which frees the billing clinicians up to see the next new patient. So your staffing plan. So all these things work together in different ways. And so that interactive variables is why sometimes we find the metrics in our field a little bit more complicated than straight running maybe a primary care practice. Spoiler alert. One of the dilemmas we have in our field is this issue of RVUs. There's a lot of pressure out there. And we just wanted to state that, palliative care does not get the same RVU weights as others. And we can have an argument and debate about that, and happy to talk about that. But the reality of it is that's where we are. So the idea here is to acknowledge that tracking RVUs, understanding how many billable services you're having is part of the metrics you want to be looking at, but it does not tell the whole story. But we're not going to win the financial story by looking only at RVU measures. Thinking broadly about our field, this is just a perspective I continue to have. We know that we often start the conversation around the value of palliative care, around cost. And I just continue to work with colleagues and programs directly where we want you to think through quality. Studies show good quality results in more appropriate use of healthcare resources and reduces cost. So it's okay to tell that story. And it's an and, it's not an or. So part of the story is how do we tell from the beginning, what are you doing in good quality to help have the impact on the goals of the organization? And we'll spend some time talking about where you spend your time is as important as the outcomes that you're trying to get. I love this slide just because it happens all the time, but get all the information you can. We'll think of a use for it later. Thinking carefully about what your metric strategy is, how to go about gathering that information and not just trying to grab anything, but really thinking strategically about it is what we'll spend some time on now. So one point here is this idea that how do we use information to get to yes? So how do we think about information in a way that allows you to tell your story, that helps demonstrate where you're having the impact, which ultimately can lead to finding better ways to get the resources you need to sustain your practice and grow it over time. A couple quick points. Number one, not everyone is going to remember the historical baseline of impact that you have had. So thinking about metrics to understand where have we been becomes an important part. And usually where systems and leaders and administrators are looking for is where's the new opportunity for savings and how do we demonstrate what that might look like? So just remember, you have to help educate others around you as to what your impact has been. Second is, important part of getting to yes and getting support is about building strategic relationships with others. Those might be referring clinicians, those might be administration, it might be in the C-suite, wherever it might be. So using that needs assessment process, using the process of going out and understanding what are the problems that your referring colleagues or your system is dealing with. What data do they have? What metrics do they use? And can you link up with that and then define pilots and scope some of your practice around what they're saying? Third is the more you can come in with specific options, ways by which you could grow your program through the data. For example, you might have just opened up a multi-specialty clinic. How do you go over and do some discovery with them, see what they're trying to do, and come back with 2 or 3 options about how you might integrate your service into that? And if you did that, what impact might it have? Use a more concrete example also in the ICU world again. A lot of the cost savings are demonstrated in ICU, shorter length of stay in the ICU. So if you spent an extra hour or 2 a week rounding to get better referrals, the return and the impact might be that you could take 1 or 2 days off of 50% of the patients you touch. Like that's an example of going into very specific options. And the last thing is this idea of the denominator. We're going to hit this a couple different times, but the key point to this one is you really want to be able to tell that story of what you're not seeing. Where are the patients that are not being touched? And how do you help tell a compelling story about what the impact you're going to have on those patients that you might not be seeing? So those are just a couple kind of ways to frame up when you're using metrics and thinking about sustainability and growth and impact, how you might frame up how you approach that. So there's macro and micro data worlds. On the macro side, thinking about national reference points, right? So how do we think about the national studies that are out there that demonstrate the impact of a palliative care service, be they quality, be they cost? And oftentimes, as I've worked with many clinician leaders and chief financial officers and others, they're skeptical of the national data. They want to know how to relate. So you do have to match it with local specifics and examples. An example might be, at the national level, we know that earlier integration of palliative care in a hospital stay within 3 days or so will increase the likelihood of having the impact on total cost during that stay or patient suffering during that stay. So if you want to propose a staffing structure that says, hey, if we could have weekend coverage and added staff to do weekend coverage, we could have conversations with patients that might have been admitted on Tuesday or Wednesday. We could have those conversations on Saturday or Sunday when they're ready. So now we're taking a couple days earlier that we're touching those patients. What does that look like? So you're taking the national reference points and trying to relate them to a very concrete local example. Back to the denominator. So this question around, who are you not hearing from? Where are the pockets of high need? And how do you frame up the kind of macro data to more of a local? An example I've been trying to sort through, even with others in our field and with practices, is we're talking a lot about health equity right now, and we're talking about access in a consistent way. If we match that with payer and financials, oftentimes there's a lot of Medicaid patients. And the question becomes, where are those Medicaid patients being seen today out in the community? They might be being seen out at a public health department. What is your system or your hospital's relationships with that public health department? And does it make sense for you to maybe do some in-servicing or some outreach to those public health departments, which then brings the fact that those patients that might be cycling through your hospital, you might have a better touch on them when they come into you. So there's an example where you're always trying to think about the strategic broader framework, but then how do you think about who you're not seeing? And is there a different pathway to get into them? You could also ask it from the question of, we're getting all these referrals from these 3 or 4 services, but we're getting nothing from neurology. Well, go over and find out what it is and what the barriers are and how you might approach that. So that denominator question is a question to ask yourself: are we getting to all of the potential patients that were there? I'm not suggesting you need to go see them all, but you're trying to make sure that you're seeing the high impact ones. So who aren't you seeing? Another example here, just to give you that sense of pragmatically how to use the numbers. In this case, you might say over a 3-month period, you collect your data and you find that 18 patients are there for 14 days before they're getting consulted by your inpatient palliative care team. Well, if you had an impact on just 100 of those days, of the 250 days that are represented by the 18 patients greater than 14 days, then what would be your value of impact if you could get those patients on day 3 or day 4? Now, what do you need in staffing or your own resource time to get those patients earlier? And we can talk about strategies about how to get earlier integration and earlier referrals. Micro, macro again, Trying to give you another example where the national comparisons might say we could see an additional 100 or 1,000 patients to get to the top quartile of programs nationally. And we've identified these 4 specific areas that we could actually do that in. And so you're trying to match the national perspective with what you can do locally. Just a couple areas of when you're thinking about demonstrating stewardship and effectiveness and useful measures. Certainly costs of your program is one way to measure it, but we want to be distinct to say that looking at average cost per FTE is one way to create a reference point for yourself internally that says, if this additional FTE costs so much, per year, but we're able to touch this many ICU days, or we're able to avoid this many admissions, now you've got an investment comparison point to compare against. So there's an example of really looking at your cost. And in this case, looking at direct costs less your billing revenue. So you end up with your net cost after you've covered some of it with billing divided by total number of patients. Other examples on effectiveness and using the word productivity here to think more about effectiveness and efficiency of use of resources. The one I always love to look at is follow-up visits. So if I'm looking at a home-based program about what is the duration that you're following patients is something to measure. Because if you're following patients longer than you need to, than is appropriate, that precludes you from seeing the next new patient. Same thing on the inpatient side. I often find programs where you're coming into them, and we'll look at the data very quickly, and we'll see that their average follow-up visits per patient is less than 1. They're probably on their heels, they're getting very late referrals, and they barely have time to get 1 consult in. Other teams might be seeing them 8 or 9 times. Well, then you can ask the other question, which is, are you seeing them too long? Do you have a process to discharge them off of your service? And what does that look like? Having those numbers and being able to speak with them with leaders and colleagues and others just makes it showing that you are thinking carefully about the resources that you do have. And then the last bucket is around obviously quality and impact. And again, an example would be, we're going to look to identify what day of stay most of our patients are getting referred to us in the hospital setting, or if you're doing a clinic-based program and you're looking at the ASCO guidelines and they're suggesting that we should have palliative care consult within 8 weeks of a diagnosis of advanced cancer. Can you look and see how well you're complying with that? Because the more you track that, the more you're demonstrating you're having the impact earlier in the disease trajectory. So timely is another one to think about. That's a service standard question. Are you tracking how long it's taking you to see patients from point of referral? If it's taking you, more than a day, you might need to start some practice that says any referrals received in by 3 o'clock, we will let our referring clinicians know that we will see them the next day. You're just setting expectations. But if you're finding yourself keep pushing off, that's an indication that you're needing something adjusted on your front end, on your referral volumes, and possibly staffing. So just to kind of summarize a couple of these themes, using the metrics allows you to better tell your story. You're trying to figure out a way to demonstrate the consistency of practice and good stewardship of the resources you have. You're trying to link your practice to organizational or referring clinician goals. You want to link to and be able to speak to what they're working through. An example recently I was on was they actually were getting ready to build a fairly large tower of some new beds, and integrating the palliative care team into the planning of that hospital site was something that had just not happened yet. So we were there, so we had to get on the committee or find someone on the committee. So you really want to find where the growth is happening and link to those goals as well. The metrics and really how to ensure quality, sustainability, growth. Capturing that non-direct patient care time becomes important. Again, if it's not tracked, it didn't happen, but how much time are you spending doing rounds with other programs and other teams and other referring services? That is value added time, and you can account for that as you're having conversations with your colleagues and with your leaders as you're talking about the staffing plans that you need. So try to capture it in some way. And then, as I mentioned about the national metrics, thinking about them in context to your local metrics. We just wanted to give you a little bit of a kind of a planning approach to think about this as well. I mean, you're not just going to start running around, like you said, on the cartoon, just chasing stuff. Step back for a minute and think about if you had a 3-year plan for options for sustainability or growth. The first piece is demonstrating the stewardship in the flawless basics, or the basics of what you're doing. So for example, how do we look at the volumes that you're seeing today and how much you might have been seeing 2 or 3 months, weeks, or years ago? Helps you understand the trend of where you've been. It also gives you a sense of a bit of a baseline about what, I'm going to use the word quotes, normal looks like, but when does high and lows look like? That just shows good basics in stewardship of the resources you have. Another stewardship example is billing. Do you track the number of patients you are seeing and the referrals in your electronic record? And is someone doing a very simple audit every couple of weeks or for 2 weeks to see whether the bills have dropped for that? And letting your leadership know that you've done that business practice just shows good stewardship of the resources. Make the explicit progress and importance on the timeliness. So again, talking about, are we meeting the deadlines of what our patients need from us? Are we able to respond effectively? Are we able to respond to referring clinicians? If we are or we aren't, that becomes part of your question about, do you have enough staff to support that? Or do we need to relook at our referral criteria? So really thinking about timeliness and responsiveness as a palliative care service and team becomes very important, because you want those confident clinicians referring to you knowing that they're going to get responsive services. Third is just to think then about, what are other specialists looking for? What are other services needing? How do we think about our 3-year plan in context to what their 3-year plan is? And then simply lay out, what are some opportunities for change or growth? If we had, if we kept our staff as it is, if we make the assumption there's no growth expectations, then what would we do to reduce volume to manage within that scope? Or how do we turn around and say, we've decided that we think it's better for us to spend time in this area than that area because we can have a bigger impact on this goal or that goal for the system. If you have opportunities and options to think about growth, and I like to go into the growth-minded perspective, but you're laying out, if we had 2 more staff, what could we do with them? If we had 6 more, what could we do with them? So thinking about that growth. And as you think about a system, thinking about it not just by site, but as a system. And then I think there's a couple, let's see if there's another. I might have skipped over this one real quickly. I do want to hit this one really quickly. It's another example of the context for numbers. In this case, you're comparing 2 sites. Site 1 shows that it saw twice as many visits than Site 2 saw twice as many visits as Site 1, but they have more than twice as much staff. So your first conclusion might be that Site 2 is not as productive as Site 1. But if you go further down in the list and you look at the cost per consult, it is actually lower at Site 2. The nuance here is that at Site 1, you might have had a higher physician presence. Maybe it's because the practice culture there was more physician, and you had to have a higher physician presence than another interdisciplinary team perspective in order to get the referrals you needed. So it's not that one is wrong or the other or right. It's more that you want to make sure that you understand the comparisons and what the trade-offs are between having one type of mix of composition of team versus another one. So I just wanted to touch on that as kind of another example as you think through how you make a compelling case for either how you're established at a site today or how you might see your growth going forward. And then we just wanted to add just a few resources. CAPC has a lot of resources. Also, the Palliative Care Quality Collaborative that has, if you're contributing data to that, a lot of great reference points you can do. And then, of course, American Academy of Hospice and Palliative Medicine has Measuring What Matters. So there's a quick, hopefully quick, somewhat relatively quick perspective. Marty, I'll turn it back to you and Steve.
Yeah, that was definitely informative and meaty and a lot of information to process. Let's take the next few minutes to have some questions and answers. I know Martin's got a question. And anybody else want to jump in?
I'm happy to jump in to give people a minute or two to simmer and think about there. So I've got A whole bunch, but I'll ask you two to start.
Okay.
to start. The first one is you had a slide about showing that we can improve quality and cost savings. Have you seen any programs that have been able to just sell based on quality? Because I mean, I think of medicine, you think of the business. Quality is wonderful. It's important. It's what matters at a human level, but the cost savings is really what pays the bill.
Yeah. So I've got two perspectives. Number one, if we, the collective we, they could be leaders at any level or palliative care teams, don't lead with quality, I don't know who is. So I always encourage people that we don't need to chase the cost. I think we should open and lead with it more than we do. Second, yes, I have seen programs and organizations and leaders, might be a chief medical officer, might be a population health person. It might be someone who practiced at a place that had really good quality palliative care that gets the formula very quickly. And finding that voice or champion within your leadership team, if you're having a hard time kind of running into those kind of cost questions, is a strategy. One of the examples I gave one time to someone, and he went out and did it, was he was really struggling with his chief financial officer. And I don't mean to brand or name certain roles, but that sometimes is where we get a little bit stuck. And so I suggested, why don't you invite the chief financial officer to come into one of your team meetings and just listen? And so he did. He left the meeting and he called up the medical director later on and said, I just didn't understand it. He said, I'd like you to actually come to the board and present to our board about what you do and how you connect the dots between these very complex patients and utilization and cost and such. And, over time, he ended up doubling his staff and service. The board is very engaged. The leadership was engaged. So you sometimes need to be the one that helps influence that strategy, even though you're hearing lots of words the other way. And so it is not a one-time event. It is an ongoing process. But if you don't talk about the numbers and talk about your work in relation to those numbers, they might perceive that you are not thinking about those. And so you want to be able to get in the conversation about the numbers, about quality, sometimes by talking about the numbers, if that makes sense.
Appreciate that. Second question. Do you think that we have any part of this wrong with trying to actually figure out our cost savings? I mean, we have to be a little bit biased, right? We're proving our own worth. We're doing our own studies on this. Is there something we're blind to? Is there something that maybe we're missing intentionally, unintentionally? I even hate to ask that question, but I want to ask it.
Yeah. So I think what we're missing now is a presence at the table in a way that acknowledges that palliative care has become a standard of care. It is an expectation. And we don't need to apologize for that. We don't need to be high on our horse about that. I'm just suggesting that we need to be more matter of fact about that. So I think what we're missing sometimes is to not apologize for the fact of, did you know that ASCO guidelines now recommend palliative care, within 8 weeks of diagnosis? Or did you know that palliative care is now in 85% of hospitals? Or did you know that, I was just recently with a trauma hospital who was safety net trauma hospital who was going for their trauma certification. And they actually needed the palliative care team to be on it because the trauma center was expecting it to be there. So I think we need to talk about the cost savings in context to a space where this is an expectation, and we should make it part of what we do. And that's why I feel like sometimes we overemphasize the cost savings and chase that a little bit too much, maybe to your point. We need to just balance the conversation to be able to talk about both. But I think it's an opportunity to lead with the quality expectation. Does that help? Or get close to it?
Thank you. Yeah, I appreciate that.
Yeah. Any other questions or perspectives? Someone had mentioned, the collaborating with provider needs. I want to just make a quick comment on that. Digging through, integrating with other services and being part of the fabric of a system, building those strong relationships with referring clinicians becomes an important part of your strategy. Embedding and integrating and feeling a part of the ICU team or a part of the cardiovascular teams in certain ways. Oftentimes too, they become the best advocates for you when you're talking about growth. And you might ask them, would you mind coming to this meeting, this budget meeting with me to talk about how we've been integrating with you? Or sometimes you can go to them to say, if they're asking for a staff, maybe you could join them with that. And then you start talking about how you might share a staff. So the more you can build those strategic relationships in a hospital, I would say in clinic settings and even in home-based settings, the more you can be thinking about them as talking about your service and the need of it, rather than you having to carry the water for that. Steve.
Yeah, so related to that comment, actually, between, I mentioned to you, in Wisconsin at least, where palliative care is present at currently 15 hospitals, and we have a wide variation in terms of the number of referrals and penetration rates. Anywhere from like 3 to maybe 12, 13%. So this might be a tough question to answer, but what's the right number and what's the right size of a palliative care program when and how much customization do you do to the site when you might be sacrificing standardization for the group overall?
Yeah. Well, our national norm data is very helpful reference points to think about where is second quartile, third quartile, fourth quartile. And if you're trying to instigate some change in your system, sometimes showing where you are relative to that can actually spur leadership to feel a little bit like, wait, why aren't we in the third, why aren't we in the top quartile, right? So you can use data that way. But I do want to acknowledge that, if I were asked that question, the first thing I would do, it's a math problem, right? Where are all the staff? What does staff look like at each site? Okay. You're going to have different rates of engagement based upon the staffing that you have. That's the first step. You might be at those different penetration or integration rates because you have a very light team at one site. So then you got to staff and compare, what do we have on staffing at hospitals 1, 2, and 3, and 4, 5, and 6. The second thing you have to look at is the demographics of the hospital. And I would say that's both in hospital, size, but also complexity of the patients. Again, you might be having a very low penetration rate, but you're seeing and taking care of patients for longer. Your practice might be more of a consult only versus a co-management model. So you're really more involved. So you're going to have lower new consult volumes. But if you feel comfortable that you're seeing the highest number and the most appropriate patients for that staff, then you can calibrate and say, we're at 3.5%, and that's appropriate at that site for these 4 or 5 reasons. So I encourage people to use your own 15 hospitals as your own kind of discovery site to be able to have reference points that might be more relevant, but really get in and understand that it might vary. You can certainly say we would like to set a strategic goal that all of our system hospitals are at 6 to 8%, because as a system, we see all these needs. But I just am always cautious to say you can't put a number out without really knowing, number one, are you seeing the right patients? Number two, do you have the staffing to do it? So I do think in ranges is a very helpful thing. You might say we would like every hospital between 4 and 8%. Maybe that's a strategic plan goal, but how you get there and which ones are which, you'd have to go deeper.
Thank you for that. And I don't know if we have time. Could we close with Martin's question and the comments?
I got one last one, and then we'll let you go. So you've been doing this, you and Lynn have been doing this for a very long time. Do you have some predictions, some foresight about how you think medicine is going to continue to change and evolve over time, and how you predict palliative care teams are going to have to continue to adapt and pivot? Any advice or wisdom that we can see if it comes true?
Oh, Lord. I've been in healthcare for 30 years. I've been able to work in payer organizations. I've worked inside provider organizations as an administrator, and I've been doing this consulting work. And so sometimes over time, it just becomes a little bit muted as to all these fluctuations that happen because, so first of all, obviously, I think major changes are happening with consolidations and mergers and healthcare becoming run more as an investment or as a business. That's happening through for-profits and private equity money coming in. We can take that as a scary thing, or we can take that as look at all the extra capital coming into our system and how do we get a piece of that. So strategically, I think finding creative ways to build partnerships, to be open to it, and to continuously anchor on what do the patients need around all this kind of chaos that's happening is kind of one guidance. And so I would say for the future, expect that to continue and be part of the process. Try not to stick your head in the sand. Obviously, access to home and models of medical homes, et cetera, are continuing to move. We had a big push through CMS and others, obviously not from COVID necessarily, but even before that, to look at home-based models and payment models. I'm seeing that spin up again a little bit and this kind of focus on population health. I think that wave comes and goes. And I think we're going to be hitting another wave where, underneath any one of those, palliative care has a value. We are taking care of the most complex patients. And so I encourage us in that scenario, the no regret action is, again, stay at the table, look around for the opportunities for you to have impact and build a relationship with your population health teams, with your case management teams that are also seeing those very complex patients. And I think the third is just got to be around this whole workforce. I think a lot of things changed for people, not only in healthcare and the presence of COVID, but I think just a recalibration of what's work flexibility look like. And I think we have to continue to adapt to that, but we still have to hold each other accountable that in a healthcare service setting, we have to take care of patients, and we may not want to have weekend coverage, but what would weekend coverage staff look like? And how do you find people that might want to flex into that schedule? So I kind of match a little bit of where I think we're going with pragmatically, what do you do? I always think about across all those different scenarios, you're never going to predict it right, but what are 3 or 4 no regret actions you can do now, regardless of what happens? And it just kind of unfrees yourself from worrying about the future. So there's my words of wisdom for a Friday morning.
Well, thank you very much, Tom. This is really informative, and I hope everybody has a wonderful weekend.
Great. Thank you all for the opportunity.